This is our 8th Cracking the Cancer Code event. We have been holding these since 2022, and since that time have actually welcomed hundreds of people to these learning opportunities to learn about the groundbreaking cancer research and care that's happening right here in your own backyard. When we launched the series, in the very first one, our goal was to create a space where the community could come together and could engage directly with researchers, clinicians, and others in the public who are interested in exploring these questions about cancer prevention, diagnosis, treatment, and beyond. Cancer is complex, and we've tried to address this in many of our sessions in various facets of cancer. It's a complex and far-reaching disease. Throughout this series, we have delved into topics that include the origins of cancer, the environmental factors that can affect cancer risk. We have explored how innovative therapies are developed right here in Calgary and how those can harness the power of the immune system to attack your own cancer. Tonight, we're going to focus on something different. We're going to focus on an emerging and critical issue, and it's the rising incidence of cancer among young populations. I think that tonight's discussion, we think of cancer only in older adults, or we typically do, but truly it's being reshaped as we speak, and it's getting younger and younger. So we'll hear more about that tonight, and hopefully we'll leave everybody with new insights backed by research that is truly reshaping cancer outcomes. This is a particularly exciting time, actually, for cancer research in Calgary. Recently, many of our teams moved into the Arthur J. E. Child Comprehensive Cancer Center, and actually we are only a few days away, from opening the doors to the public next week. So we have been waiting for this for so long. I'll say in June, I'm just going to go off script a little. In June, we moved about 120 people over to the research spaces in the new cancer center, and that was principal investigators, so researchers, their students, their staff, and I was amazed at how smoothly that went. We had some movers come in, move consultants, Alberta Health Services, planners, and in the morning, people came with carts, rolled on carts. And by the end of that afternoon, there were folks doing experiments in the new cancer center. It was very exciting and inspiring. But this is happening right now with the rest of the clinical services, so that we are opening soon to the public. Super exciting. So the research, let me get back to the research facilities. The research facilities cover more than 100,000 square feet in the new cancer center. And that houses labs that focus on understanding cancer biology, research groups that focus on developing and testing new diagnostics, new therapeutics, and groups that look at enhancing cancer prevention, survivorship, and patient outcomes. Of course, none of that progress would have been possible. We wouldn't be here with the new cancer center if it weren't without the support from our community and folks just like you. In 2021, we called on Albertans to help us make the Arthur J. E. Child Comprehensive Cancer Center a world leader in research, care, and education through the Own Cancer campaign. This fundraising partnership between the University of Calgary, Alberta Cancer Foundation, and Alberta Health Services saw those amazing organizations come together with the goal of raising $250 million. Although the campaign is nearing its end, if you've considered contributing to the campaign and you haven't yet, there's still time to make a difference. This campaign supports cutting-edge research, some of that research you're going to hear about tonight. And of course, cancer does not stop when a campaign stops, right? So you can continue to help us own cancer by donating through the University of Calgary even after the campaign closes. You might have seen this table on your way in, but on your way out, I encourage you to stop by the table and chat with our team if you're interested in supporting us. They'd be happy to answer any questions you might have. So now it's my pleasure to introduce our wonderful moderator for the evening, Christina Frangu. Please join me in welcoming Christina.
Hi, everybody. It's so nice to be back here tonight. I think this is the 5th time I've been asked to moderate one of these events, and it's always a real privilege for me to be here. In my day job, I work as a journalist and as a teacher, and so I think a lot about science communication and how we take complex science ideas and explain them to the public, and I think this is a really outstanding example of how this could be done. Tonight is also particularly special to me because, as some of you may know, my husband was a resident here in Calgary who was diagnosed with cancer on the last day of his residency, and he was 36. We were in the Arthur J. Child Cancer Center wasn't even talked about then, but I know what a difference it will make to patients. So thank you for having me here. Tonight, as you've heard, we are talking about one of the more distressing trends in cancer right now, and this is the surge in cancer cases among younger adults over the last decade. We hear of cancer diagnoses in mothers who have just given birth, a track star training for the Olympics, a writer who has just bought her first home. And I expect all of you have a story like this. And as a friend said to me this week after we heard about another very close friend who was diagnosed with cancer, she said, "I don't feel old enough to have so many friends with cancer." And so that's what we're going to talk about tonight. The focus is early onset cancer, and that's really focused on cancer in someone between the ages of 18 to 49. As you walked in this evening, you may have noticed the statistics on the screen behind me. And I do want to read out a few just so that you have an idea of the enormity of the change that we are talking about. Young adults in their mid-30s today are experiencing 2 to 3 times more cases of small intestine, kidney, and pancreatic cancer compared to baby boomers who were born around 1955. Young adults today are more than twice as likely to develop breast cancer than the baby boomer generation. Canadians born in 1988 are 5 times more likely to have rectal cancer than someone born in 1943. These are alarming statistics, and every single one of these numbers represents a person and their loved ones who are facing a life-changing diagnosis, and a diagnosis that has arrived before they have even hit the midpoint of their expected lifespan. And tonight, it's my treat to be able to introduce you to researchers who are exploring this changing landscape of cancer here in Calgary. So I'll give you the rundown of how it will work. We have 3 speakers. They will each come up and speak to you for about 15 minutes, and then they'll join me on stage for a discussion. And I promise you we will be taking audience questions at the end. So if something arises for you as they're speaking, just hang on to that thought, and we will get to you at the end of tonight. So with no further ado, I will jump on ahead. Our first speaker is Dr. Corinne Dahl. She is a radiation oncologist at the new Arthur Child Cancer Center, and she serves as the clinical associate director of the Arnie Charbonneau Cancer Institute. She is also a clinical associate professor in the Department of Oncology at the University of Calgary. Dr. Dahl will help us understand what may be driving these early onset cancers. Please join me in welcoming her to the stage.
Great, thank you, and good evening, everybody. Cancer is a life-altering diagnosis. There are many physical, psychological, and social ramifications that come when someone faces such a diagnosis. As a radiation oncologist, I see the cancer toll on patients and their families. It's a really significant toll. And when someone goes through this huge life change, they're not just confronted with fear and uncertainty, they also face overwhelming stress, anxiety, juggling treatment schedules, and coping with challenging side effects that can come up with cancer treatment. So after treatment, it's not just everything stops. There are follow-up visits, there's investigations, there's a lot of intrusive thoughts about recurrence, physical and sometimes permanent changes to the body. Their lives move forward on unexpected courses compared to their contemporaries. So what I've described is difficult to deal with at any age, but imagine hearing those words, "You have cancer," as a young adult in the prime of your life. the impact on you as a person, your social life, your career and family, unimaginable. So I want to put you in the shoes of two such individuals. So first, Daryl, he's a 39-year-old father. He has 2 small kids. He works full-time in construction. About 6 months ago, he noticed that his bowel movements were less regular. And although it wasn't the easiest thing to talk about, he couldn't ignore it when his stools became harder to pass and when he started to see blood. Concerned, he went to his family doctor, who upon examination noticed a rectal mass and referred him for an urgent colonoscopy. And then during this procedure, a mass was found and a biopsy showed rectal adenocarcinoma. He had imaging, and this was consistent with a stage 3 cancer, locally advanced cancer. He was recommended to have surgery, but because of the advanced nature of the cancer, preoperative chemotherapy and pelvic radiation was also recommended for him. Next is Susan. She's a 33-year-old mother of a 2-year-old daughter. She's just come back to work as an accountant. She started having heavier periods a few months ago, and this progressed to longer episodes of bleeding and then pelvic pain. She saw her family doctor, and the family physician noticed an abnormal pelvic mass, and so Susan was referred on to a gynecologist, and then she was ultimately diagnosed with an advanced endometrial cancer. So these are just 2 examples of stories that have become, unfortunately, more and more common. So both Daryl and Susan were previously healthy, and in fact, neither have a history of cancers in their family. So when I first started my career in oncology almost 25 years ago, it was very rare to see a patient under 50 in our clinics. As trainees, we were taught cancers are diagnosed in an older population. It's a disease of aging. But more recently, we've seen this increase in a diagnosis at a younger age. And this is a pattern shown in multiple countries, not just in Canada, and it's been observed since the 1990s. In fact, a person who was born in 1950, who now would just be 34 years old, has 4 times the risk of rectal cancer compared to somebody born in 1950 who would be now 74 years old. And some have even called this phenomenon an early-onset cancer epidemic. And while we haven't seen this increase across all cancer types, it does include a wide variety of cancers, and many of them are in the gut or gastrointestinal type cancers. So why is this happening? What's driving this epidemic? Well, some have said this increase is directly related to early detection, so screening, like FIT testing, colonoscopies for colorectal cancer, and mammography for breast cancer. But this is not the whole story. In fact, many of these patients present too early to even have had screening. And a disturbing trend is that actually many of these cancers are being diagnosed at more advanced stages or show high-risk pathologic features under the microscope. So when a patient is diagnosed with a cancer, one of the first questions is, why did this happen? What caused this cancer? And unfortunately, the factors implicated in why younger people are developing cancer is not entirely clear. It's not really just one thing. It's more nuanced than that. What we do know is that exposure to certain risk factors early in life, like as a kid or young adult, can play a role. We also know that there are many changes over the last few generations in terms of our habits and where we live, the environment that we live in. And going back to that earlier example, if you think of 1950, a long time ago for many of us, maybe some of us haven't been born then, but very different childhood exposures and experiences and habits versus somebody born in 1990, for example. So if you think of those habits, as a society, unfortunately, we're becoming more overweight. We have a higher incidence of obesity, with half of the cancers with increasing incidence actually related to obesity. Our diets are filled with unhealthy options, high in saturated fats, red and processed meats, refined carbs, sugar, and ultra-processed foods. Sugary beverages and alcohol are on the rise. And meanwhile, we're not consuming enough of those healthy options, whole grains, fiber, fruits, vegetables. The pandemic opened more opportunities to have fast food delivered right to our doors. Ultra-processed carbs, fat, and sugar come with just a tap on our phones. And speaking of phones, many of us are spending hours and hours a day on our screens and tablets, and generally we've become a more physically inactive society. So in terms of where we live, urban environments, cities, we live in cities. We're being exposed to chemical carcinogens and toxins without even being aware. And in fact, the National Cancer Institute has identified 27 environmental substances that can cause cancer, including things we eat, aflatoxins found in corn and peanuts, chemicals like cadmium in dark chocolate, unfortunately. We also breathe in harmful substances like radon and smoke. And we hear about the increasing prevalence of plastics and microplastics. And recent studies actually show that multiple carcinogens can exist in food contact materials or food packaging, and they can actually leach or migrate into our food. In fact, more than half of the early onset cancer types that are arising in incidence are actually in the gut system, as I mentioned. And I think this importantly turns our attention to the impact of the gut microbiome. So microbiome, what is that? So it's a collection of all the microbes, such as bacteria, fungi, viruses, and their genes that naturally live on our bodies and inside of us. And there in fact are up to 10 times more bacterial cells in your intestines than you have human cells in your entire body, which is an amazing thing to think about. And many factors influence the health of the microbiome, including all the factors I just discussed in terms of the dietary things, and including other things, as including whether you had antibiotic exposure at a young age or whether you've had antibiotics over your lifetime. And a healthy microbiome plays a key role in our immune function. So the microbiome can modulate cancer development and risk, progression, and response to treatment. So now let's talk about how exposures to certain infections can impact your lifetime risk of cancer. So there are even some organisms that are directly carcinogenic. They cause cancer, such as Helicobacter pylori for gastric cancer or stomach cancer, and 7 species of viruses, including EBV or Epstein-Barr virus that can cause some lymphomas and nasopharyngeal cancers, hepatitis viruses, B and C, causing liver cancer, and HPV, which can cause cervical cancer, anal cancer, head and neck cancer. In fact, 13% of cancers are actually caused by infections. Other microbial members have been shown to indirectly cause cancer, including an E. coli that produces a substance called colobactin that can damage DNA and trigger DNA double-strand breaks and can cause chromosomal instability, which may lead to cancer. I'm going to remind you again of Daryl, so our 39-year-old father of 2 with rectal cancer. So what we're seeing in our clinics and who's coming into clinics is now being reflected within the research. And recent studies have shown that this particular alarming trend in the increase of colorectal cancer in younger adults is again 4, even up to 5 times the risk of rectal cancer for a young person versus somebody who was born, as I mentioned, back in the 1950s. So why is this? Well, if we consider colorectal cancer specifically, again, several studies have linked childhood or early adulthood obesity. That seems to be a common thread here to early onset colorectal cancer risk. And other factors include physical inactivity, prolonged sedentary television viewing time, metabolic syndrome, type 2 diabetes, cholesterol, high cholesterol levels, the dietary factors that I mentioned earlier, and then other things like inflammatory bowel disease, Crohn's disease, ulcerative colitis will also increase the risk for early onset colorectal cancer. The majority of these cancers, though, are not hereditary, but there are some patients that have inherited cancer syndromes, such as Lynch syndrome and familial adenomatous polyposis, and it's estimated about 1 in 6 patients who have an early onset cancer may have one of these genetic traits. So what about Susan? So again, obesity has been determined in many studies to be associated with endometrial cancer. It's a hormonally driven cancer, and estrogen is produced in the peripheral fat cells, and so obese patients have more circulating estrogen, which can stimulate the endometrial cells to become cancerous over time. And in fact, about 1 in 5 patients may also be genetically predisposed to this type of cancer, commonly, again, Lynch syndrome. So by the time I meet with a patient, it's common that they're facing a complete information overload. And it's our job in the clinic to guide them through this process involving the best guidance in an unsure and unique situation. So when we think about conventional treatments, They include surgery, systemic therapy, and radiotherapy, and often a combination of these things. And these are well-studied effective treatments with the ultimate goal of eradicating the cancer or reducing the impact of the cancer on the individual's life. We do know that each of these kinds of treatments have their own specific side effects, and each of these side effects potentially can last long after the cancer is eradicated. For example, many of these treatments may impact fertility and hormonal production. And while this may not be something that's important for somebody at age 50, it certainly could be at someone who's only 30 years old. And while no treatment is without the risk, especially when considering a younger patient population, we are certainly miles ahead of where we were even just a decade ago. Many of these treatments can in fact be tailored to a younger adult patient population, depending on their wishes, and additional measures can be employed to reduce the impact of these treatments. As an oncologist, I can tell you how critical it is to have a detailed discussion with patients before starting treatment. We need to know their wishes, we need to know their thoughts before we start our treatments. So remember, Susan, when we consider surgery for a patient with endometrial cancer, the standard of care is to not remove the ovaries for patients who are younger than 45 years. The only reason that the surgeon would want to remove the ovaries is if it was suspected that they were involved with the cancer. And if this patient requires pelvic radiation, the surgeon can also do something very interesting, which would be called ovarian transposition, or actually to move the ovaries away from the radiation volume and outside of the pelvis. For males, avoiding irradiation of the testes or using gonadal shielding can be used to reduce the impact of radiation. So there are many unanswered questions, and research on early onset cancer is needed. And even though there's information to be gained by looking at large database studies, these continue to be somewhat limited given the lack of detail on early life exposures. Prospective cohort studies where individuals are followed over time and these details are recorded are needed to really try to figure out what's going on here. So what can an individual do to help advance our knowledge? Well, many things, I would say. Participation in clinical trials that evaluate cancer risk, including giving consent at the cancer center, or if you're involved in other studies, to collect specimens for analysis of biomarkers, would really further what's going on in terms of the biologic factors for cancer development. And what else can we do for ourselves and for the younger generation that importantly patterns what we do? Well, raising awareness of this early onset cancer phenomenon, including public health and provider awareness that this is happening, this is real. Promoting healthy lifestyles from childhood. And then optimizing nutrition. You want to keep your microbiome happy, and you can do that by eating more fiber, plant varieties, polyphenols, those are the brightly colored fruits and vegetables, and fermented foods. Minimize the obvious toxins, alcohol, tobacco, use of plastics where you can. Physical activity, especially outdoor activity, and monitor your and children's screen times, promoting healthy activity outdoors and aiming for a healthy weight. And I would say most importantly, listen to your body and don't ignore symptoms that don't go away. Information is power, and the more we learn about what's driving early onset cancers, the more we can do to prevent them. Thank you.
Thank you, Corinne. So our next speaker is Dr. Sarah McQuinlan. Dr. McQuinlan is an obstetrician, gynecologist, and surgeon, as well as a clinical assistant professor in the Department of Obstetrics and Gynecology at the Cummings School of Medicine. As a researcher and a clinician, Dr. McQuinlan works in a very important area of cancer care that has really only developed in the last decade or so, and that's looking at fertility preservation and finding ways to preserve fertility in a population that is suddenly facing a life-changing diagnosis. Sarah.
Thank you very much. So thank you for allowing me to share on a topic very close to my heart. My own journey to building a family was long and required lots of assistance, and my goal is to offer the same support to other patients and families. As a pediatric and adolescent gynecologist, I have the unique opportunity to support patients and their families in accessing fertility preservation. It's as rewarding as it can be heartbreaking. My goal with every patient who walks into our clinic is to provide options for preserving fertility and advocate for better follow-up on reproductive goals for survivors who face a cancer diagnosis early in life. My patients are often too young to be thinking about having children. It may be decades away, but the work we do now can keep that option available for them in the future. I completed a fellowship in pediatric and adolescent gynecology more than 10 years ago in Australia. There it was ingrained in me that the discussion surrounding fertility preservation was the standard for all patients diagnosed with cancer before they started treatment, no matter their age. As part of the fellowship, we set up a protocol that was embedded within the electronic medical record to facilitate documentation, discussion, and ongoing follow-up of fertility goals for all patients. This is the same protocol that I and many of my colleagues are putting in place here in Calgary. I'm happy to share that since coming to Calgary, we've established our own local fertility preservation program at the Alberta Children's Hospital. This means all patients who will undergo treatment that has a high risk of infertility can take steps now to help them have their own biological children years from now. Let me start by setting the scene. Could everyone in the audience close their eyes and focus on the story I'm about to share? Imagine yourself as someone diagnosed with recurrence of acute lymphocytic leukemia, a type of cancer of the blood and bone marrow, which will likely now require a bone marrow transplant as treatment. The tough news of recurrence is confirmed just as you're finishing your 4th year of university. You're about to start your career and embark on a new chapter in life. This devastating news is coming after you've previously completed 2 years of cancer treatment, including a rigorous regime of chemotherapy while you were in high school. Now you are faced with the prospect of a bone marrow transplant. Your life suddenly looks very different. As you digest this information, you're also met with the reality that this new treatment plan could result in an 80% risk of premature menopause. You could be in menopause before you've had a chance to have your own biological children. This is the devastating reality that many young adults facing a cancer diagnosis must also confront. In our clinic, I see often patients and their families' first thought is survival, obviously, in the face of a cancer diagnosis. But the second is often the potential for biological children in the future. Through our work, we can provide these families immense hope in a very difficult time. Fertility preservation is an incredibly important consideration for survivorship among all young cancer patients. How much fertility will be affected by cancer treatment depends on a number of factors, including the type of cancer, the treatment required, and the age of the patient. For example, someone with a very aggressive form of cancer who needs high-dose chemotherapy or radiation to the pelvic organs may have a higher risk of lost or reduced fertility. Additionally, the older the patient is at the time of diagnosis can also have an impact. Fertility naturally declines after the age of 32, and cancer treatment can accelerate that process. But cancer affects fertility across all age groups. I really want to stress that it doesn't matter if you're a child or a 32-year-old woman. Research shows that adolescent and young adult cancer survivors face more infertility and have fewer live births compared to their siblings. A 2023 study of young cancer survivors, however, shows that many survivors do perceive their infertility risk as higher, but they often overestimate or underestimate the actual risk. The study highlights that those who had high-risk treatments were generally able to recognize their increase in fertility risk. However, overall, survivors' perceived risk didn't always align with their actual infertility risk, as shown by blood work or the return of menstrual periods. The key takeaway is that ongoing counseling about infertility risks during survivorship can help bridge this gap and reduce fertility-related stress and help guide family planning decisions. I'm happy to say that here in Calgary, I believe we have an exceptional long-term survivor clinic for childhood cancer survivors who have transitioned into remission and recovery. Our team meets with patients on a yearly basis to address fertility and reproductive needs. However, we know that these same services are reduced for young adult population, who have often been returned to their family doctor once they've reached remission. Risk perceptions are some of the precursors to health behavior, such as seeking out information and accessing and complying with medical care. By identifying a gap in survivorship knowledge on actual infertility and premature menopause risks, healthcare providers can tailor their communication and counseling, fertility surveillance, and subsequent need for fertility treatment to the individual. We know from studies that young cancer survivors often feel less attractive due to body scars and experience lower satisfaction with sexual function. Survivors also report anxiety about how cancer may affect their fertility. Many feel uncertain about their fertility future. They believe infertility could be managed, and they know that about 15% of the population will struggle with infertility, but they feel they need to inform a partner early in a relationship. Despite these concerns, survivors express confidence in the healthcare system's ability to provide fertility assistance if needed. These findings highlight both the emotional impact of cancer on survivors and their trust in medical support for fertility-related challenges. This is a role that we do not take lightly. I, with my colleagues, am working to make sure that every patient has access to medical help with fertility challenges that may arise from their life-saving cancer treatments. Now, we've heard a lot about the importance of the potential for future fertility to improve self-esteem and provide the long-term goal of a biological child in the future once a patient has completed their cancer therapy. So what options actually exist for these patients? The field of fertility preservation has grown exponentially in the last 10 years and has readily become available in Canada. The first step is ensuring tailored treatment to the individual, including their goals of treatment and future fertility wishes. If their hope is to be able to one day have biological children, we do have several options. The most successful option for fertility preservation for patients with ovaries is embryo cryopreservation, meaning combining an oocyte from the ovaries, those are also called eggs, and sperm to make an embryo. This is commonly what we think of as IVF. The chance of having a baby from one round of IVF is approximately 50%, but it does require two people, one with eggs and one with sperm or pre-purchased sperm. The process takes around 2 weeks, which can result in a delay to starting treatment. Some young adults, like our patient finishing their 4th year of university, may be single and might consider egg freezing, known as oocyte cryopreservation, to protect their fertility in case treatment leads to early menopause. Egg preservation is pretty much what it sounds like. It starts with about 2 weeks of preparation, where patients give themselves daily injections to boost egg production and have transvaginal ultrasounds to monitor their ovaries. When it's time, the eggs are then collected through a procedure done via the vagina, and they are frozen for future use. A person's cancer treatment might start right after this. And then there's ovarian tissue cryopreservation, a newer yet well-established procedure that involves removing and freezing an ovary for future use, either to help with fertility or hormonal support. It's a relatively simple procedure with 3 small cuts on the abdomen and is ideal for those who need immediate treatment or are not ready for egg freezing. This option is offered at the Alberta Children's Hospital for kids, teens, and young adults. The frozen ovary can then be thawed and placed either in the pelvis or actually even in the forearm when the person is ready to have a baby in the future. The tissue lasts about 7 years and produces eggs that can be fertilized through a process similar to IVF. This novel method has led to many successful births worldwide. While there are many options for fertility preservation available, I do want to point out that cost remains a huge barrier. It can run into the tens of thousands, and that is a lot for anyone, but very hard for a young adult just starting out. Fertility preservation is unfortunately not a publicly funded service, although there are small supports through a few different oncofertility-focused charities. The most important point I've learned during my journey offering reproductive care to pediatric and adolescent gynecology patients is that patients should be offered the access to the different fertility options as soon as possible so that they can make the right decision for themselves. And then they should be able to revisit their goals for reproductive care in the future as they enter remission and their life goals start to change. We aim to keep as many options open to patients as possible throughout the rest of their lives. Many of our patients have decades and decades of life ahead, so we return to this conversation in the years after treatment. It is very exciting thing to be able to talk about having biological children, making life even in the world of a cancer diagnosis. At diagnosis, patients may not be ready to consider fertility preservation, but a few years later, before premature menopause occurs, they may decide on a different option. It's important to revisit reproductive goals, period control, contraception needs, and long-term fertility goals. And the options for surveillance could include watching for the return of periods, blood tests to look at the hormones, or ultrasounds to look at the ovaries and uterus. There is an important lesson for all of us in this. I want everyone to take away the importance of routinely and regularly advocating for discussing fertility preservation in cancer survivors. This will improve long-term self-esteem and confidence, as well as increasingly the likelihood that you will have biological children. It is okay as a patient to ask at your next visit to have your fertility reviewed. As young adult survivorship grows, we need to recognize the whole patient and the lifetime of plans that lies ahead for them. Allowing patients to envision the potential of a biological child in the future is paramount today. Thank you.
Thank you, Sarah. So our next speaker is Dr. Miranda Fidler-Benodia. She is an epidemiologist in the Department of Cancer Epidemiology and Prevention Research at Alberta Health Services and an adjunct associate professor at the Cummings School of Medicine. She does really fascinating work, and among some of her projects, she studies the long-term effects of cancer and its treatment in survivors who are diagnosed during childhood, adolescence, and young adulthood. She recently co-authored a study that was published in The Lancet Public Health that showed that cancer incidence has been increasing in progressively younger groups in the United States for 17 different types of cancer. She will talk to us about the way that cancer uniquely impacts young people and how cancer care has to change to meet these needs. Miranda?
The last speaker told you about the importance of fertility in the cancer journey of a young person, a unique and an important concern for this cancer population, one that's often pushed aside with the urgency of a cancer diagnosis. Now, I want to dive a bit deeper into the other ways a cancer diagnosis at a young age has different implications because of their life stage, and share more about what we are doing here in Calgary to improve care and outcomes for this growing survivor population. To begin, cancer diagnoses before age 50 occur when young people are still finding their way in the world. They're completing their education, launching careers, becoming independent, forming adult relationships, and making plans for the future. So when a young person receives a cancer diagnosis, they are faced with their own immortality for perhaps the first time. This realization is coupled with the fact that they are very likely going to need to receive difficult treatments like radiotherapy or chemotherapy. Cancer is a difficult diagnosis for anyone, but for a young person, that means putting a pause on their life, a pause that can have a lasting effect even when the shock of the cancer diagnosis and intensive therapies is over. And that's because research has shown that having a cancer as a young person makes us less likely to hit the same milestones that many of us take for granted, like graduating with a degree or getting promoted at work. For example, while around 11% of 35 to 39-year-olds were unemployed at some point in the last year, the equivalent percentage among young cancer survivors was 17%. And while around 44% of 35 to 39-year-olds make less than $40,000 in personal income in Canada, that percent is 10% higher, at 54% for young cancer survivors. As you can see, young cancer survivors often end up being less financially stable, which can impact their overall well-being for the rest of their lives. A cancer diagnosis during young adulthood is associated with distress and anxiety immediately, but also poor mental health in the long term. Indeed, when we investigated poor mental health among Albertan young cancer survivors who survived at least 5 years from the cancer diagnosis, we found that 61% of these young cancer survivors were diagnosed with a psychiatric disorder. This is huge, and this likely reflects not only the experience of having dealt with cancer and all that entails, but also the knock-on effects of that cancer diagnosis, like feeling disconnected from peers and social life that result in isolation, or forced dependence from having to move back in with your parents, or just more generally disrupted future plans. Because young people have less developed coping mechanisms, understanding the unique psychosocial needs of this population is key in order for them to receive the care and support they need. Because as you can expect, what someone needs at the age of 35 to thrive is going to be very different from what someone needs at 65. Fortunately, cancer survival is fairly good for young people, with over 80% on average expected to survive at least 5 years. And this percentage is continuing to grow among those more recently diagnosed, thanks to improvements in treatments and supportive care. However, we must recognize that the cancer therapies used to achieve such good survival rates come at a cost. And that's because the treatments needed to achieve cure can negatively impact other organ systems. So for example, young cancer survivors are more than twice as likely to develop cardiovascular disease and are similarly around twice as likely to develop another cancer. Indeed, our work here in Alberta has shown that even 30 years after their cancer diagnosis, young cancer survivors experience 30% more deaths than what we would have expected in the general population. This truly highlights the persisting impact of a cancer diagnosis at young ages for the rest of their lives. Moreover, our research suggests that we will continue to make improvements in these survival and that these young cancer survivors will face growing risks of adverse health outcomes, or what we call late effects of their cancer and its treatment. Late effects are important for many reasons. They're important to the survivor because they experience poorer physical and mental health compared to their peers. It's important to the healthcare system because this growing population has very complex healthcare needs, and thus the healthcare professionals need to know how to monitor and survey for these late effects as they age. And it's important economically because late effects make people less able to contribute to the economy and put more costs on the healthcare system. I also want to take a moment to recognize that when a young person faces a cancer diagnosis, it does not stop with them. That diagnosis has a rippling effect to their families and support systems too. And that's because many of these young people are also caregivers, whether it be to their aging parents or their own children. Indeed, we know the consequences of having a parent facing a cancer diagnosis are extreme for the child themselves. They're at increased risk of poor mental health and poverty. In 2020 alone, an estimated 2,600 children lost their mother due to cancer in Canada, emphasizing the intergenerational impact of cancer at young ages. So, you may be asking, what can we do and what are we doing here in Alberta? Well, the first thing we're doing with events such as this one is increasing awareness of cancer at young ages. We know that young people are diagnosed with cancer at later stages, and this could be because they aren't aware that cancer can occur that young. Signs of cancer at young ages include an unusual lump or swelling, unexplained tiredness, easy bruising, pain, unexplained fever or illness, loss of appetite, or unplanned weight loss. I don't know about you, but as a mother of 2 very small children, I could easily write off multiple of these symptoms to just the daily demands of life. Constant exhaustion from always being on the go. A breast lump that I just assume is a blocked duct from breastfeeding. Or the cold that doesn't go away from all the daycare germs. It's easy to overlook these symptoms, but you know your body best. If something doesn't seem right, go to a medical professional and advocate for yourself. Delays in a cancer diagnosis for young adults can also occur because of errors on the healthcare provider's part, with research showing that dismissal of symptoms and misdiagnosis commonly leading to longer times to diagnosis in this population. An extreme case of that occurred right here in Alberta for a man named Greg Price. Some of you may be familiar with the healthcare journey I'm going to speak briefly about, as it was shared in the short film, Falling Through the Cracks, Greg's Story. So Greg was a young, physically fit mechanical engineer when his doctor identified a concern with one of his testicles during a routine medical exam. His doctor ran some tests, and everything looked fine to him. 400 days would then pass, when Greg would be bounced between over 10 medical professionals and told to sit tight or that someone would be in touch soon. 400 days before that lump was diagnosed as testicular cancer. By then, the cancer had already spread, and unfortunately, Greg passed away from his disease 3 days after his surgery, at the age of 31. While this is certainly an extreme case and also reflects a fractured healthcare system at the time, it is not unique. I've heard similar stories from the patient partners I work with about how they were prescribed muscle relaxants for years to deal with back pain that was actually a Ewing sarcoma, or how they had multiple visits to doctors for large red spots on their calves and a swollen testicle that were dismissed, but were in fact leukemia. The fact is, the rising number of cancers at young ages isn't a historical issue. It's a now issue. And as a result, we need to bring medical professionals up to speed on these emerging trends as well, to ensure that young people receive the timely diagnosis they deserve. I also want to encourage you to partake in cancer screening. Cancer screening can detect precancerous cells at an early stage so that when removed, they prevent a cancer altogether. Cancer screening can also detect cancer at earlier stages so it improves survival. Here in Alberta, we have cancer screening for cervical cancer beginning at age 25, colorectal cancer beginning at age 50, and breast cancer beginning at age 45, though it can start earlier if you speak with your healthcare professional. And for the very young people in the audience or people with young children, I want to emphasize the importance of HPV vaccination, which significantly decreases the risk of cancer later on in life and is worthy of looking into at a minimum. As I begin to close my talk, I want to acknowledge that this evening has focused on a difficult topic: rising cancer diagnoses at ages when cancer shouldn't be occurring. But I also want to emphasize that researchers, clinicians, and the wider Cancer Care Alberta community are working to improve care, experiences, and outcomes for these young people facing a cancer diagnosis. I highlighted some of the research I'm involved in, but we are doing so much more. We have a physical activity trial that is trying to help young cancer survivors become physically active again after completing their treatments, so that we can reduce or eliminate those late effects we talked about. Next year, we're going to start recruitment for young cancer survivors so that they can complete a questionnaire and help us understand what is behind these rising rates of cancer at young ages that are currently unexplained. And we're also looking at patient-reported outcomes to better understand the unique supports that are needed for this population when going through treatment or end-of-life care to ensure that we're always offered patient-centered care in Alberta. And of course, we have the Arthur J. E. Child Comprehensive Cancer Center, which will open its doors on Monday. The Arthur Child is not only the largest cancer center in Canada, but it's the first center in Alberta with a dedicated space for young cancer survivors to go to. Our hope is that having this space will allow young cancer survivors to find other individuals going through a similar journey. In this space, we will also include resources about how to navigate the cancer system as a young person, as well as existing studies and ways to get involved in research. Another wonderful element of the Arthur Child is that there is a child minding area that will open in the future. This space will reduce barriers for young cancer patients to receive timely treatment and follow-up care by allowing their children to be properly supervised at the cancer center while they meet with their medical teams. To put simply, the Arthur Child is thinking forward about Albertans and how to provide the best care to them, including the young cancer survivors we talked about today. By combining basic health services, clinical and population health in one building, the opportunities to improve care, experiences, and outcomes for future Albertans facing a cancer diagnosis at young ages is limitless. So, in closing, while young people with cancer have generally been overlooked because of the fact that cancer is relatively rare at these ages, as we've heard multiple times, cancer is a disease of aging. I hope our talks today have emphasized the significant impact that cancer can have not only on the individual, but their families and support systems, the healthcare system, and more widely, society. Here in Alberta, we recognize that the profile of cancer is changing, and as a result, we are focused now on ensuring care is adapted to meet these young cancer patients' needs so that they are not only surviving their cancer treatment, but thriving afterwards. Thank you.
Does this mic work? Yes. It's very hard to figure out how to turn this one on, so I was nervous. Thank you. I have heard those talks a couple of times, and I still feel rocked by those stats every time I listen to the three of you speak. And tonight, as I was listening to you, I was thinking like we seem so, in some ways, passive about this. These trends are just happening, and I don't know how we can stop them. And so I have a really big question of each of you to start, and that's if you could make one change that you thought would start to turn this trend around, what would it be? Is there something we could do?
That's a great question. Maybe if we had the magic answer, it would be better. I think, unfortunately, the reality is that we don't know what's going on. When we see that trends are showing increases in young people, we don't have the detailed level data on each individual to know what they were exposed to in their lifetime. So we tried to draw these hypotheses that, because these cancers relate to excess body weight in older adults, maybe that's it. Or maybe these are linked to smoking, depending on where the site is. But the truth is we really don't have the answers to understand how to reverse these. I think what I would suggest at this stage is because we don't know those answers, the best we can promote is understanding that this is occurring and awareness, as I tried to highlight, not only among the young people, but the health professionals, so that whilst we can't avoid these cancers right now, or many of them, we can at least improve survival and outcomes afterwards.
Sarah, Corinne, do you have anything to add?
I thought that was an exceptionally good answer, and I think from my point of view, the biggest thing is just trying to make healthy choices on a daily basis, because those are the only things that we really do have some type of control over.
Yeah, I mean, awareness is huge. Awareness, public awareness, which is, again, the reason for this night. And then public health, policy, understanding that this is happening. And there are lots of wonderful publications that have acknowledged this, shone a bright light on this issue. Here locally, but also internationally, this is happening concurrently in many different countries, this awareness and this outreach. And even in, I think about 2 weeks from now, there's a very, very large symposium happening. That's the colorectal, well, it's actually through the CCRA and Colorectal Cancer Resource Action Network, but it's actually called Early-Onset Cancer Symposium. And there's 57 speakers, and they're from primary care, they're policy, public health people, there's researchers, there's oncologists. It's Canadian in its base, but there's international speakers there, and that is basically acknowledging what's happening and also how to deal with it. How are we gonna turn this around? So the good news is that it's been acknowledged, and the questions of what to do next are being addressed.
Now, there's lots of controversy about when screening should start and what guidelines say. Would lowering the age of screening guidelines make a difference? I know it's not going to reduce the incidence, but would it make a difference?
Yeah, it is a really good question. You're right. It's quite contentious right now. So the big example is breast cancer screening, which in the US, they lowered it to 40 years old. And so there was a call, including by the Canadian Cancer Society, that Canada should do the same. The fact is the US did that to try to decrease disparities between blacks and whites. And there isn't really evidence showing that decreasing the age will improve outcomes. I think when it was recently reviewed in the last year in Canada, they held the recommendation to be 50. So here in Alberta, as I said, it starts at 45, and it does open it up to people starting at age 40, if you speak to your healthcare provider. And I think that really, at least with the patient partners I talk to, that reflects what they want, even if, maybe the evidence doesn't support it. But I think the important thing to always remember is there's always this balance of, does it prevent mortality? How many additional people would it distress because of false positives? What's the burden to the system? Can we handle all those additional people getting screened? So it's certainly not an easy question to answer. I know there's also simulations that have happened recently in Canada for colorectal cancer, and they do show that mortality would decrease by lowering it to age 40. But we have to remember, whether our system could impact that or whether it would have a ripple effect to other areas. So I think probably it would decrease mortality, but it may, at this time, it's not being recommended to lower.
Sarah, Corinne?
I'll maybe mention one thing beyond that. So a lot of people think I have to wait till I'm 45 or 50, too bad, I've got a strong family history. Well, if you have a strong family history, you need to talk to your doctor, because screening can start even 10 years younger than a first-degree relative had their diagnosis. So, having a conversation with your family, cancer history in the family, and sharing that with your primary care physician, I think is really, really key, because you may be eligible to have earlier screening, and you don't have to necessarily stick to that common number. That's for the low-risk population or the average risk population. So a lot of people don't know that, and I think having that information will be very powerful for a lot of folks that aren't aware of that.
Sarah, I have a question for you about fertility preservation. A young person is diagnosed with cancer, we'll say a young adult, and is terrified, wants to start treatment. Does the decision to pursue fertility preservation delay the beginning of their treatment for cancer?
It really depends on the option that they choose and the timeline. Some treatments, like a bone marrow transplant, take time to get organized, and so patients may have time to undergo if they have a partner or they've already pre-purchased sperm, because their plan was to always go ahead with embryo cryopreservation, or what we think of as IVF, then they would have time. For some treatments that are going to start the next day, then they may only have the option of ovarian tissue cryopreservation, because that can be done at the same time as the placement for ports for chemotherapy, and then they can start chemotherapy the next day.
And do you see patients deciding not to pursue it because of the costs associated with it?
Definitely, cost is a barrier to some patients accessing fertility preservation. The cost can range from approximately $3,000 for ovarian tissue cryopreservation, but that doesn't include storage cost and cost to utilize the tissue later in the future, whereas egg freezing or oocyte preservation, embryo freezing, those costs can approach $15,000 to $25,000, which is a lot when you're already faced with a cancer diagnosis and a change in sort of how you envisioned the next 5 or 10 years of your life.
And does anywhere in Canada cover that, or is it almost always out of pocket?
So across Canada, it's not covered for like cancer treatment. In certain provinces, they do cover sort of one round of IVF, and so there may be some coverage there. The issue is that the publicly funded options can be slow, and so when you're needing to access this treatment to preserve your fertility quickly, you may not be able to wait for that publicly funded spot to come up. And in Alberta, we have no coverage for fertility preservation or fertility treatments anywhere.
Just thinking about the numbers we're talking about and the pressures already on our oncology workforce, I mean, we have a shortage of physicians across the board, but do we need to think about really changing how we were training and how many people we were training who specialize in oncology?
Yes, we do. Yes, I think so. And I want to also just mention that the percentages and all those, 4 times, the rates, very scary, but the numbers themselves still are small, thankfully. But the cancer incidence, continues to increase because of aging, and of course we have a bigger population year to year, so the numbers themselves of people with cancer are increasing, and that will always happen as we age and as we increase our population. So we definitely need more specialists. Again, new cancer center, can't wait till Monday. Shiny new office, clean office. And I think we have a great opportunity to fill that space with world-class people, which we already have actually, but I think we'd have to think about increasing our numbers to meet this demand all across the board with the different specialties.
And Corinne and Miranda, you both talked a lot about what we see as some of the drivers of this, and we've talked before about how hard it is to find something that is a direct cause, and I'm going to add another element into this. And I often hear climate change cited as a driver of cancer, especially in young populations. Is that true? Do we know?
So I would say we don't know. When we think about what may be causing these cancers to rise exclusively at young ages, we try to think of exposures that these individuals are seeing and others aren't. So when I think of things like the forest fires that we see here in Calgary, that is something that we're all exposed to, though perhaps there could be a sensitivity or like a sensibility for young people particularly. But cancer generally takes a long time to develop. So if we're thinking about forest fires and maybe their relation to lung cancer, we're probably not seeing the effect yet. I've done no research in this, so this is hypothetical in nature, but this is what I would guess.
I'm guessing you've done more research closer to this than anybody else, but does anyone else have an answer to that?
I would just add that the environment is different. Like, those two very different decades, the 50s and the 90s, what happened, what did that group from the 50s experience in their life exposures versus the 90s, who are now 34 years old? The environment has changed tremendously. And so there's something in that we think, researchers think, but we just can't isolate and have that causation. There's, associations perhaps, but the causation piece has not been identified.
And are there cancers where we're not seeing this trend? And I think of cervical cancer and lung cancer with declining smoking rates. Like, what are we seeing? Is this across the board with cancers? What are we seeing?
No, you are right. So cancers that we typically associate with prevention are doing much better. So fortunately, we're seeing cervical cancer is going down among those more recently diagnosed, which probably relates to HPV vaccination as well as screening. For a range of cancers related to smoking, so lung cancer, lip and oral cavity, laryngeal, we are seeing decreases among younger generations as well. And yeah, so I think there's definitely, and melanoma, that's the other one that's decreasing. So increased awareness about sun protection or decreasing all that sun tanning use in the past. So cancer prevention is working for some cancer sites where we know the cause. And that's where we're kind of at fault right now.
And so I think about we have this vaccine, this HPV vaccine. Are there other vaccines that we will see in our lifetime that you could see making a difference in other cancers?
I guess the easiest ones would be infectious,
Okay.
similar to HPV. So Dr. Dole had mentioned like Helicobacter pylori for stomach cancer, or there's a range of different viruses that are linked to cancers as well. So maybe those. But I guess you would say that they're less common in these in Canada, a bit more common in developing countries.
And I'm going to open it up to the audience for questions right away here. I do have one question that I want to ask to each of you, but before I open it up to the public, and that is there one thing that you do differently in your life because of the time you spend thinking about early cancers, early onset cancers?
Oh man, I'm the worst. So I am the absolute worst. I've been in this field since I was 21. So pretty much the first thing I think of when myself or my family have a symptom is that it's cancer.
Yeah.
So
Same.
not great. But I think I recognize the signs and symptoms. I'm very proactive for advocating when I think I need testing, even if it's the best example was a breast lump when breastfeeding. I made sure to get an ultrasound because I've heard those stories of people getting breast cancer in that phase of life. But yeah, I think I advocate more for myself, and then I'm also just aware of, the more typical risk factors we associate with cancer to avoid. Yeah.
Sarah?
I think as a gynecologist, I do see a lot of endometrial cancer, which can be associated with obesity. And for myself and my family, we're very active because we feel, one, we like to be outside and we like to be like going swimming and going for walks, and we have a dog, which makes that so much easier. But I would say being active has been really important and feels like something that is easy for us as a family because we like to do it to control.
Yeah, and I would say something similar, the activity, but also I think more recently becoming involved in microbiome research. I read this quote: "You can't change your genome, but you can change your microbiome." and to that, the whole foods, the choices that you take into your body, that will change the makeup of your microbial friends inside of you. And I always think it's not a mini me. There's so many of them. It's a maxi me. That's like more than you inside of you. So I think kind of being thoughtful of that some years ago and thinking, okay, I feel like opening Hawkins Cheesies, but maybe I should have some berries and yogurt. Just think better choices more often, I would say. Who likes Hawkins Cheesies?
So we do have two lovely runners running up and down the aisles with microphones, and so if you have, I see lots of questions. I see one right there at the back by the woman with the black, and then we have a couple more down here. And I guess before, I'll just say there's obviously going to be a lot of questions, and so please try and keep them brief and keep them questions. And I know we have like a really great panel up here, but they also can't, it's not fair to ask them personal medical information, questions about personal medical advice. And so please try and keep your questions broad and keep them a question.
Okay, thank you very much. My question is, have you seen any differences in the characteristics of this particular cancers, including the survival rate when they're contracted by younger people?
Okay, I can start. So as I mentioned, survival is actually generally a bit better for young people. Obviously, it varies by cancer type. I think that relates to the fact this is a healthier population that doesn't have as many other chronic health conditions when they're going through cancer treatments. As mentioned also, we do see that generally the cancers do seem a bit more aggressive or diagnosed at later stages, which again makes the cancer more difficult to treat. And then for some cancer types, like breast cancer, we do see the actual cell type is different, or the hormone receptors. So for example, and for people familiar with breast cancer, triple negative breast cancer is more common at younger ages. So it can be that the distribution of the cell types or hormone receptor status varies by age as well.
Yeah, I have nothing more to add. That was a good answer.
Next question.
Thank you very much for this presentation. It's been most informative. Could you just speak to what's being done in pediatricians and general physicians' offices regarding information for them to use for diagnostic tools and awareness in patient consultation to support your patient population as far as avoiding late diagnosis?
It's a great question. I'm personally not involved in any of the, knowledge translation to family physicians in the province. What I can say is actually one of our patient partners is in medical school right now, and she was able to relay back to us that they are learning about this. So I'm not sure really about how much the older generations who are currently practicing are aware of these rising trends, but I think it's very promising that we are recognizing this is occurring and that we're teaching the future generations about the most common cancers at young ages and the signs and symptoms of them.
Yeah, and I'm hoping that, as people understand this phenomenon, and, of course, this phenomenon will probably lead to more chronic diseases in general with cardiac disease and diabetes. These are chronic health issues that are related to all these different factors that we talk about. Hopefully that will lead to more teaching and habit forming in the younger generation, and, for kids, because this is only going to turn around if things improve at a very early age. These are cumulative exposures or habits or environments that are probably causing this. Again, more research is needed, but I think that that information and trying to change some of those habits at a young age, and it's not just pediatricians. I would say it's the family of young kids that really need to pattern activities and healthy behaviors.
Just to go a bit more off that, so we will have a study launching next year where we're just asking actually people younger than 40 years of age about what they know about cancer and the signs and symptoms, as well as screening programs in the province. So that's not people who have cancer, that's the entire population. So if you see our Instagram or Facebook ad, please complete our study, because we don't really know what young people know about cancer. And so that can really help us understand maybe what populations we need to target or how we can reach them to increase awareness about, so they know as well, because probably most young people are not attending things like this. So we need to find new ways to reach out to them.
We think they're all at Halloween parties, but when you say our Instagram, that's the Arnie Charbonneau Cancer Institute's Instagram?
No, it will actually be an ad that
Okay.
pops up.
Okay,
Yeah, so.
the Coming School of Medicine? Okay.
I was going to say another nice thing actually about the province of Alberta is because there's an electronic medical record for the entire province, we actually have quite a good recall system for like cervical screening, where patients actually receive letters when they are due for their pap smear. So this takes the onus actually even outside of the family physician or general practitioner and allows patients that may not have providers to still be able to know that they need to go for cervical screening.
And if I'm recalling this correctly, I think Greg Price's family, they were so active in their advocacy after he died, and one of the things that they really called for was a better integrated health record system so that faxes didn't sit on someone's fax machine when they were away on vacation. So I think that is, at least in part, credit to his family for pushing for that and being so open with his story. More questions? I see one down, some further down here.
Hi, thank you so much. Such an informational session. I'm a healthcare provider, also moving into the Cancer Center, very excited for that. But one question we get a lot of, which I think even myself, I'm wondering now, based on the recommendations that you made around some of the lifestyle choices that are within our control, is there so much information out there that patients and providers, myself included now, I'm wondering where do we get the best resource or source of information about healthful foods? Like you mentioned some of those things we can do, high fiber, low sugars and processed foods, but if someone was looking or if a patient was asking a provider for a good resource and not needing necessarily a referral to a dietitian, do either of you have a good resource that you would recommend?
Yeah, so there's a website called Healthier Together, I think .ca, and so it's through AHS, and it's a cancer prevention website that has like a toolbox with different information about how to be healthier and prevent cancer. And so it hits on smoking, diet, everything. And everything's all in one place, and it's meant for the public, so it should be accessible to everyone as well. That would be my recommendation.
There were a few more questions lower down on both sides.
I want to thank the panel tonight. Thank you very much. So with cancer happening in the younger ages, I'm really interested in coming to the conversation about fertility and women. So 2 questions, if you don't mind. Have people done a deep dive on the impact of contraceptives and fertility? So this is being more proactive. And then the second piece to that, with these young women being on contraceptives for so long, it's going to be these hormones are going to be very skewed numbers for a very long time. And so, yeah, is there, when do these young women get a chance to have their hormones accurately read? Thank you.
Yeah, so to be able to determine hormone levels, it depends really on what type of contraceptive device that you're using. So a copper IUD has no hormones in it, and so hormone testing can be done at any point. IUDs like the Mirena IUD or the Kalina IUD, which have some progesterone in them, typically we don't truly worry that much about their effect on the hormone levels because the hormones act locally at the level of the uterus. When you're talking about like the oral or the patch or the vaginal ring, combined contraception that has estrogen and progesterone, typically it is out of the system within 2 months. And then when you're thinking about like the Depo-Provera injection, which is an injection you get every 3 months, that in fairness can take up to 2 years before, depending on the length of time that you've been on the Depo-Provera injection for return of menses and ability to test the hormones. So definitely, we don't want to be having unplanned pregnancies, so it can make it sometimes tricky when following fertility after a cancer diagnosis.
This question is for Sarah. You are talking about going into the Alberta Children's Hospital for dealing with young kids, adolescents, for fertility preservation. Is there consideration around pre-puberty? Like, is that something that you look into as well, or are these options just for kids who have gone past puberty?
Right. So for patients that produce sperm, unfortunately, at this stage, there is no options for prepubertal saving of sperm because it's made once you've gone through puberty. There's definitely investigations going into testing or like removing testicular tissue, similar to removing ovarian tissue, to see if eventually sperm can be produced. And so we're hoping that potentially by next year at the Children's Hospital that we'll be able to, still experimentally, but remove testicular tissue from males that are prepubertal before they go through high risk of failure treatment. For patients with ovaries, we are routinely offering ovarian tissue cryopreservation for prepubertal children.
Do we have any more questions? Oh, there's a couple more down here.
Hi. Yeah, I was just going to ask about, I really love the fact that Alberta keeps track of data for all of the citizens, and a lot of provinces don't have that. But I'm just wondering if that could be a place where you could collect data. You mentioned that having survey data from the patients and from population could be established. And even just to compare the younger population with the older population, because if cancers are only increasing in the younger population and you're not seeing it in the older group, do they have a different diet? Like, I would think, I hope I eat better than my kids, but, I don't know. So I'm just wondering, have you considered other ways? Another one is that one of the things about medicine is you should do no harm. And yet you mentioned that antibiotics might cause potential issues with your microbiome. And one of the ways of tracking that in the population and which antibiotics they took is if those medicines were kept track of in some kind of historical database, so you'd know who's been exposed to what. But anyway, that's my question, I guess, if it's a question.
Yeah, you are completely right. We are very fortunate here that our electronic health administrative health databases, our registries, can easily be linked, and I do have that data. The problem is that it only goes back to the early 2000s. So when we're talking about people born in the 1990s, what they were exposed to, we don't know. And for sure, the people in the 1950s, we have absolutely no idea. So I would say in the future, it is bright. In Alberta, we have not only detailed information about maybe their smoking status or their BMI based upon when they're going to their doctor. We'll also understand their detailed cancer treatment therapies to try to understand late effects and survivorship risks and get towards precision medicine. The problem we're dealing with is that when we're talking about these increasing trends, we need to really have exposure data for a long time. And these electronic medical records are recent. And that's why we usually end up looking at what we call a case control study, whereas we compare people who have cancer to those who didn't, and we make them think back to what they were exposed to, and then we do comparisons. So that's what we're going to start next year. In regards to antibiotics, that data system exists. We will be able to understand antibiotic use and link it to different health conditions in the future. But I want to acknowledge also that some of the things we're talking about are not avoidable. You know, if you're sick and you need antibiotics, I mean, we need to give you antibiotics. And so certainly I wouldn't want to suggest shaming because people were doing what felt right at the time and we just didn't know. A lot of these exposures we don't have control of, or they were medically necessary. And so there's always a balance.
Mm-hmm. I'll mention does anyone remember the campaign, Not All Bugs Need Drugs? Basically, you know, antibiotics are for certain conditions, for certain illnesses, but not for viruses. So it was sort of a public outreach because a lot of people thought, okay, I have a cold, I don't feel good, I want antibiotics. So we're not saying they're bad. We're saying that the use should be judicious and should be for the right condition, but they are life-saving, obviously. They're fantastic drugs used for the right situation, but they can alter the microbiome for sure.
I have a follow on that question, and it strikes me, listening to you speak, that we would have a much better understanding of what's happening in Canada if we had a national integrated electronic medical record system. Yeah?
For sure. When we're talking about cancer in young people, you can see I'm not reporting data on Alberta. We don't have enough people. So we have to go to a bigger scale like Canada, or that's why we were able to detect even more cancers in the US because the population is greater. So when we're talking about still outcomes that are fairly rare, like cancer at young ages, even though it's significantly increasing, you really need to have a lot of people to be able to detect associations. So when we're trying to then think what is causing these rises, we need even more people. So that's where different data sources that combine, that does exist for some things, but not really the exposure data that we're necessarily talking about, except maybe some environmental data.
We had more questions. There's a couple down here.
I was wondering whether you know if there's a difference between countries in the rates of cancer in young people. Like if you compare the United States with some countries in the EU with more, I guess, strict controls on things like caffeine and junk food.
Yeah, it's a great question. And we did do those studies. So I would say we're generally seeing the same increases in many countries that are high income. US, UK, Canada, Australia being the most common ones. A lot of this relies on having really good cancer registration data, which not all EU countries do have. But it is important to recognize that just because you're high income, you're not experiencing the same things. So for example, if we take France, excess body weight is not a huge issue there, but smoking surely is. And so their cancer profile and what is causing cancers there is going to be different. So we definitely don't lump it in. And then when we think about the developing world, we are not seeing these increases at all. So when we're talking about increasing risk of colorectal cancer or endometrial cancer, things like this, those countries are still dealing with infectious cancers. So they're seeing increases in cervical cancer, Kaposi sarcoma related to HIV. So again, a very different cancer burden in their young population.
I thought I saw a hand at the very back.
So you said that like young adults have a lot of screening, but what about screening for youth, like teens or younger?
For cancer?
Yeah.
Nothing. Our first cancer screening program starts at 25 for cervical cancer. There's nothing earlier than that, and I think that reflects that cancer is quite young, or that we don't have detection available for the cancers that are more common in youth, which is generally leukemias or lymphomas.
So if I can't get screening, then would the symptoms vary?
The symptoms would be the same. So when we talk about screening programs, what that means is that you receive an invitation in the mail telling you that you should go get screened for whatever cancer according to your age. But what I showed on my slides, the signs and symptoms, what I talked about, that's just self-awareness. So when I talk to people, there's no evidence, but just being aware of lumps and bumps, it's not going to hurt you. If you see something abnormal, or having your partner look at moles that seem abnormal. So I think when we're talking about being aware of cancer at ages before cancer screening occurs, it is mostly through self-awareness and looking at these signs and symptoms that don't seem right, and then seeking help from your healthcare professional. Don't put it off. Like I talked about the individual, the healthcare system, but there is this invincibility factor for young people that they're not thinking they're going to get a serious chronic condition like cancer. And we just assume we're healthy and we write it off to like tons of things. So it really does take knowing your body, knowing what seems right or wrong, and then seeking help when you need it.
I will follow that up with screening really means testing in patients who don't have symptoms. It's a way of trying to early detect patients who are not symptomatic. But if someone is symptomatic, they need testing, not screening. So, for example, the patients that I talked about, they went right to testing. They didn't go through screening because they were having symptoms. So if you have symptoms and you're concerned, see your family doctor, and that will lead to testing, not screening.
Do we have any more questions? There's one more down here, and I think this will be the last one, and then we'll get some closing remarks maybe.
I'm wondering if anybody is looking at epigenetics, like the impact of what happened to the mother or the grandmother even, and the impact on next generations.
Okay, so I can say for sure epigenetics is being looked at somewhere in the world. I'm not personally familiar with it happening here. What we are doing is when we're recruiting those young cancer survivors, we're actually recruiting their parents too. And because we realize that the young cancer survivor is probably not gonna know if they were breastfed, at what term they were born, like in the pregnancy they were born, in utero exposures to smoking, things like this. So when we looked at the literature and found that these early life exposure, really kind of parental or in utero exposures, were quite important at young ages, we realized that we needed to expand our study. And so that's the way we're currently doing it. But I'm personally, that's not a skill I have to look at epigenetics.
This is a little bit outside, but as an OBGYN, we often see patients before they're pregnant to talk about optimizing them in pregnancy, both if they have already chronic disease develop or just in general in terms of like healthy choices, thinking about like what vitamins are beneficial throughout pregnancy. And when we see people throughout their pregnancy, we do a lot of education on lifestyle changes that can either improve their coping throughout pregnancy, improve their chances of successful delivery in whichever way they want to deliver, and what things they can do in that postpartum period to set them up for another pregnancy.
Well, before we close for tonight, I just had one more question for the three of you, and I just want to. Every journalist is always told, ask your person if there's anything they wanted to add before you hang up. And I just wanted to ask each of you for one last thought, that if you wanted to leave our audience with one thing tonight, what would it be?
Oh boy. I would say maybe reflect on this night and ask yourself, is there one thing I can do that's different that I'm doing now that I think may help my microbiome? I've heard a lot about the microbiome. I heard a lot about different things tonight. Maybe just, and you can't do everything all at once, but maybe just making a change and seeing if you can stick with it and seeing if it maybe helps you feel a little bit better. That's what I would say.
I would honestly say from a fertility preservation point of view, I really think there are a lot of patients who may not have even had the option of fertility preservation previously because it just wasn't as available. Ovarian tissue cryopreservation is still new in Canada and Alberta, but that potentially people who are now in survivorship are having periods every month, are potentially even using contraception to avoid unplanned pregnancies, but maybe they need to be advocating to their family doctor to just have things reassessed, because we know so much more now than we did before, and there may still be a window where if biological children in the future is important, there may be things that you can do now to secure that future.
I'm at a loss, but I'm gonna go maybe something general. So we know in Canada that pretty much 1 in 2 individuals will face a cancer diagnosis in their lifetime. So while this presentation today focused on cancer at young ages, I think the messages for self-awareness and being advocates for yourself in the healthcare system is important. And definitely take advantage of the systems that are in place to improve your outcomes, like cancer screening or other prevention initiatives, because we know we can't treat our way out of cancer, we can only prevent it. So I hope this was a good experience to learn about how we can prevent cancer going forward at all ages. And the signs and symptoms I shared today are applicable to everyone. So hopefully knowledge is power.
Well, thank you very much to the three of you. You've been so generous. Thank you. And so I just want to say thank you to our partner, the Calgary Public Library, for giving us a home for this series. And from all of us, thank you to the Arnie Charbonneau Cancer Institute and the Charbonneau Trainee Association. Thank you to the caterers for the cookies and the treats. And to you, all our audience who show up every single time and show up on a Friday before Halloween to listen to this. We really appreciate it. Thank you so much. Oh, and the next event is in February, and the dates will be shared online in the coming weeks. So get home safely, everybody.